Hello and welcome to the first of a series of seminars for the Purpose Health Coalition. This is going to be a series of seminars that looks at levelling up at inequalities in the sphere of healthcare. And I'm going to introduce the panel that we've got with us for the next 3/4 of an hour to an hour. First of all, my podcast partner in crime, Jackie Smith, is here, not in that capacity, I hasten to add. She chairs the Barts Health NHS Trust and the Barking, Havering and Redbridge University Hospitals NHS Trust. Laura Hobbs is Director of Corporate Affairs at the Devon Partnership NHS Trust. Anne Hepworth is Director of Strategy and Partnership at the Barking, Havering and Redbridge University Hospitals NHS Trust. Sarah Thomas is Associate Director of Learning and Organisation Development at Sussex Community NHS Foundation Trust. Patricia Davis is Chief Executive of Shropshire Community Health NHS Trust, and Helen McKenna has the most difficult job in the NHS. She is Chief of Staff to Jackie Smith. So welcome to you all. A lot to talk about on regional equalities in health, but let's start with Jackie. She's going to outline the purpose of this seminar and the areas that we're going to cover over the next hour. Over to you, Jackie.
Okay, thank you, Ian. And the whole issue of health inequalities has, I think, quite rightly become much more central to the conversations and the action that we're taking in the NHS at the moment. Let's not forget, the NHS was created on the basis of providing healthcare free at the point of need for everybody, regardless of income. And of course, that's the principle that continues to drive the provision of our services. But we only have to look outside the organisations that all of us are representing to realise that our ability to be able to provide good healthcare, and even more importantly, to provide good health outcomes, is determined by a whole range of things that exist outside our organisations, and in some cases that exist outside the healthcare system altogether, what are sometimes known as the social determinants of health. And of course, that also will be likely to differ from place to place, even within England, never mind more broadly across the UK. So how we identify those, how we address them in our organisations, how we tackle them is a really increasingly important part of healthcare. And all of us on this webinar come from different areas. It's a real pleasure that Anne Hepworth, who's in one of the trusts that I chair, is also on the call. So I'm going to focus a bit more on the Barts Health side, and Anne's going to focus on the Barking, Havering and Redbridge side. But we've also got people from other areas as well. So, Ian, I think it will be great today for us to be able to reflect both on the areas that we serve and also the actions that we're taking to try to tackle those health inequalities, and how that may or may not differ actually in different regions of the country. So that's the basis on which we're going to have this discussion. And I'm happy to say more, but let's just leave that as an intro for now.
Oh, let's go around the panel. If you can all introduce yourselves a bit, explain what you do, and also why you're so passionate about this subject of solving regional inequalities. Laura Hobbs, let's start with you.
Thank you so much all. Lovely to meet everybody as well. So I am Laura Hobbs, Director of Corporate Affairs at Devon Partnership NHS Trust. We are Mental Health, Learning Disability and Neurodiversity Trust in the Southwest. We cover Devon, and we also have services covering as far as Bristol. We're also a regional provider collaborative. The Southwest Provider Collaborative provides a range, commissions a range of services, for secure adult eating disorders and learning disabilities. We have a wide range, might we say, of service provision and commissioning responsibilities. My role, it doesn't sound what it is. I used to be the Head of Equality, Diversity and Inclusion for the Trust, and when I had the very fortunate opportunity to take this director role, my request was that I took the exec leadership for EDI because it's something I've been very passionate about my whole life. My upbringing, my family heritage is part of it, but a general passion for ensuring equality for all is just something I think that drives us, and that's why we're here. So in the Southwest, we work with a huge range of other providers, other organisations in public sector and wider. And we have quite a geographical spread for my trust. So it's a very interesting time for us as obviously integrated care systems become statutory, and we are working in new ways to work across systems. So I'm watching and also taking part, I think, with caution, but with huge hope in the new ways in which our organisations are going to start to look at partnership in a much more meaningful way around the people we look after and the people we...
And doing it all with the age of seagulls, if I hear correctly.
I did wonder if it come through. See, on Teams, that blocks out the background noise.
Does it?
Yes,
No,
my office door is open and there are seagulls overhead, so you can hear right by the coast in Devon.
I'll probably get dog interruption when the postman arrives, so I warn you now. We'll come on to what might be the main differences as you perceive them, Laura, of the differences in what you do in your area compared to maybe Sussex, Shropshire and East London as well a little bit later. Anne Hepworth, let's come to you.
Yeah, thank you. So no wildlife in Romford that I can report, I'm afraid. Anne Hepworth, I'm Director of Strategy and Partnerships at Barking, Havering and Redbridge University Hospitals Trust, which is a mouthful, isn't it? And we are an acute trust. We serve 3 boroughs in outer East London and have 2 main sites at Queen's Hospital in Romford and King George's Hospital in Ilford, but also provide services out at Barking Community Hospital, and are also now starting to think about how we extend our services out into the community as a result of thinking about inequalities and inequalities of access around acute care. So my role is, well, it's great for a start. I've been here since February, and much of my role is about being externally focused and starting to work with the emerging place-based partnerships. And what that means is we start to talk in depth about population health, and as part of that really start to talk about inequalities and how we as a partner with local authorities, with community mental health partners, etc., and with the community can start to actually do things differently in the way that we provide services to do something to close some of those inequalities. Because I'm a firm believer that if you're not doing something positive about it, you're probably contributing to inequalities. So that's my role, and why I'm passionate about inequalities is last year when I was working across London, I was working as part of the COVID vaccine programme, and I was leading an improvement programme around uptake and starting to think about how we can increase demand of uptake of the COVID vaccination whilst not increasing those inequalities. And so learn a huge amount, just so much about the reasons for inequalities, what's driving inequalities, and also different communities' perceptions of us as the NHS and how we contribute to those inequalities. And it just made me think, I've been working in the health service for 30 odd years. Why has it taken me so long to really get fired up about that? So it does mean that for the last decade or so of my career, I'm going to be absolutely focused on this.
Let's go to Sarah Thomas. Hi, Sarah.
Hi, Ian. Thank you. I'm Sarah Thomas. I'm Associate Director of Learning and Organisational Development at Sussex Community Foundation Trust. And the Trust does what it says on the tin. It serves the community of almost all of Sussex, a tiny bit not included. And in doing that, we need to ensure that we are not inadvertently disadvantaging members of that community. So we're looking particularly, we've got a clear corporate objective this year about reducing service inequities, because we know that across the patch we deliver a wide range of services, some of which are explicitly about reducing inequity, but some of which, as Jackie said, by the very nature of the people accessing or not accessing those services, there may be inequities caused due to more social factors. My job is to look after and develop our workforce and to be responsible for our workforce strategy. And throughout COVID, we've delivered some throughout and in spite of COVID, we've delivered some amazing things in terms of initiatives, but we know there is diversity of experience within our staff due to either protected characteristics or where they work or the role they carry out. So we're really keen, I'm really keen, that we work to reduce that disparity. I get personally frustrated when I see inequalities across the system, which are often created unwittingly, but are avoidable. And so I'm completely passionate about that we're delivering treatment and care equitably, that we're actually an employer of a large workforce, and we're a stable organisation in the community. So a lot of our initiatives that I get involved in are about working with the wider community to enable a wider group of people to access and become part of our workforce.
Thank you very much. Patricia Davis, familiar face to Levelling Up Goals seminar watchers. Welcome to this one. Just describe what you do in Shropshire.
Yeah, I'm the Chief Exec of Shropshire Community NHS Trust, and very similar to Sarah, we cover the whole of the county, including Telford and Wrekin, which is a separate local authority, but we cover that 511 population. We have a number of challenges around inequalities, mainly related to the rurality of how we provide service. Over 60% of the Shropshire local authority boundary is rural, and that brings a lot of issues relating to connectivity, IT, transport, etc. And we have a predominantly ageing population, although we do have areas of inequalities, particularly relating to children and young people. In terms of passion around inequalities, I'm a woman originally from Wolverhampton, one of the most deprived areas in England and Wales, so understand what it's like to live within an area of acute deprivation, and spent 23 years of my career, over 30 years of the time that I've been in the NHS, working in the southeast, predominantly in the East End of London or North Kent, which again have significantly high levels of inequalities. And when you talk about inequalities, people think about that level of urban inequality. And something that I'm really passionate about now in terms of inequalities is raising the issue and understanding of rurality and rural inequality, which seems to have been left behind, frankly, in all of the government propositions and discussions about levelling up and inequalities. And we have some real inherent issues relating to inequalities within our rural areas. For example, we have the highest levels of county lines within Shropshire. We've got the highest levels of looked after children and imported looked after children in England and Wales, or the second highest. We have the highest number of multiple siblings within families. We have the highest number within the Shropshire area of under ones taken into care in the whole of the West Midlands region. And people don't kind of think about that when they think about Shropshire. They tend to think of a little bit like Kent and Medway. I know you live in Kent live in Kent, and people tend to think of those kind of areas of predominantly health and wealth, hunter, welly wearing, barber jacket wearing folk that don't actually
I don't have any of those things.
I'm sure you do. But you take my point. So there is a huge issue in terms of that rural inequality, which I think we have to raise. We have to raise the awareness of, and I'm sure people like Sarah and others from Devon understand that quite acutely as well. So that's a real passion of mine at the moment, the inequalities and how we address that. And I think as a community trust, particularly similar to what Sarah said, 90% of my staff live and are residents, patients, service users within Shropshire, Telford and Wrekin. And community services, I think, are best placed along with local authorities to really start to be the glue that addresses some of these kind of issues.
It's interesting what you say about rural areas, because in the Levelling Up Goals seminars, in virtually every single one, we talked about areas that had maybe special circumstances, which might be rural areas or coastal areas. So we'll come back to that a little bit later. Helen, let's come to you.
Thanks, Ian, and hi, everyone. So I'm Helen McKenna. I'm Chief of Staff to Jackie Smith in her role as Chair of Berks Health and Barking, Havering and Redbridge NHS Trusts. And I've been in the role for 3 months, and part of the reason I took the role, apart from obviously the opportunity to work with Jackie, was also the opportunity to work across two trusts that are really determined to go further on tackling health inequalities in North East London. And the trusts that I work across serve some of the most deprived parts of London and some of the most ethnically diverse parts of England. So there's a big job to do and a huge opportunity to improve health and reduce inequalities. And in particular, I'm excited about the work that we're doing as two NHS hospital trusts together, because our scale gives us huge reach and the potential to play a leading role in levelling up London. In terms of why I'm passionate about health inequalities, I think at the crux of it for me is fairness. So health inequalities are avoidable, unfair, and systematic differences in health between different groups of people. And in my mind, it just really simply isn't fair that by virtue of where you live, all the characteristics with which you're born, your chances of having poor health outcomes are greater. So that's behind my passion.
Very interesting you mentioned that word outcomes, which nobody else has mentioned here. You've all, or the way I've interpreted it, you've all talked about inequality of access, but Helen's the first one to mention inequality of outcome. And I think from a consumer's point of view, if that's the right word here, outcomes are surely what's most important, Jackie.
Oh, absolutely. And I think what we've been talking about is a way of hopefully trying to get to equalising those outcomes, because one of the things that has been clear, for example, to us at Barts Health during the course of the pandemic, is that people have had different outcomes dependent on their previous health conditions, on their ethnic background, on whether or not on what their sort of social deprivation is. It's been really stark to us, and we've actually worked hard at Barts Health to measure that. And what's more now, we're trying to make sure that as we get rid of the backlog, as we work on that we're doing that in a way that doesn't make that even worse. But what we've also see, of course, because we're in an area in North East London which does have high levels of deprivation, that is very ethnically diverse, that has therefore, but also has high levels of childhood illness and bad maternal outcomes, as well as people tending to get some of the diseases of older age at a younger age than you would imagine. What we've also got, therefore, is high rates of chronic conditions. We've got severe mental illness, more prevalent than might be the case elsewhere. We've got under 75 mortality rates for cardiovascular disease and cancer that are disproportionately high. I've talked about maternal and child health risks, and of course the unequal impact that COVID has had that we're now trying to address. So it is about how people access our services, Ian, but it's also about recognising that how people live and what their backgrounds are will, alongside how easy it is for them to access services, determine what people's outcomes are going to be as well. And this isn't to say, oh, there are inequalities and there's nothing that we can do about it. Actually, what we're discovering in the health service, when we turn our mind to it, is that there are lots of things that we can do to make sure that health outcomes do become more equal. It's not a sort of, it's not all doom and gloom. It's a challenge, but there are things that we can do to change it.
By the way, everyone, if you want to sort of jump in, if somebody's saying something that you fundamentally disagree with, or you've got a point of information, please feel free to do so. Patricia, when you listen to Jackie's list there of issues that she's having to grapple with in North East London, how much of that resonates with you? And maybe throw another question into this. We have a national health service, but it isn't national, is it? When we're talking about inequality of access, inequality of outcomes, this whole idea of postcode lotteries comes into play here, that you can access a service much better in one part of the country than another. Is that something that local health providers have got to grapple with, or has there got to be much more initiative from national government on that?
I think it's some and some, isn't it? So I think the what Jackie was describing, it absolutely resonates with across Shropshire, Telford and Wrekin in a slightly different way. You know, again, you know, as a woman from Wolverhampton and having worked in the East End and North Kent predominantly, you can see those inequalities. Absolutely, you can see it, touch it, feel it on every street corner almost. But we have the same kind of problems within our community and pockets of huge deprivation. And Jackie's absolutely right. It isn't just your geography and where you are, although that can complicate things in terms of access and therefore outcome, but also your background and all of the different sort of elements that Jackie described. So it's how we as a local community can, I talk about some of the work that we've done in Shropshire, Telford and Wrekin, reaching out to what has been determined before or described before as the hardly reached groups. They're not hardly reached, they've hardly been reached. And actually, when you physically go out and start to have the conversations, I was struck by one of the colleagues on the call talking about her experience of the vaccination programme. As the lead provider for the vaccination programme across Shropshire, Telford and Wrekin, with our local authority colleagues and public health colleagues, physically going out to different groups and providing them with the service. You know, these people weren't anti-vax. It's just that if people are living chaotic lives and have got other priorities like how they're going to pay their rent, how they're going to get a bed for the night, then it's really difficult for them to engage in services. And I think traditionally, both locally as a health service as well as nationally as a health service, we tend to provide these services and say, aren't they great? Why aren't people using them? Rather than really understanding where folk are coming from and what their needs are.
Okay, just before you go on, Anne wants to jump in.
Yeah, thank you. And it's kind of supporting all of that entirely. So on the vaccine programme, we used the WHO model, so the World Health Organization model, to help us frame the work that we were doing. And there's 3 points to that. And one is convenience. So it comes back to that access point again. One is confidence in using the service, and that was huge. And you know what I didn't realise before that was how many communities just don't trust the NHS. And don't trust the NHS because we're an arm of government, but also don't trust the NHS for other good, really, you know, strongly held reasons about some of the discrimination that they have experienced in contact with health services. And the third and final one, so it's convenience, confidence, and the final one was complacency. And that's not just complacency of people not wanting to access a service, but it's also people perhaps not having the information about the service because perhaps they're in a controlling relationship, etc. So that was really helpful. But what we found was with every single different population group in every single area across London, the real success in terms of increasing access and reduce, and particularly to those groups who wouldn't usually come to it.
Oh, Anne, you've frozen. We'll come back to you in a moment when you've unfrozen. Laura, let's come to you.
I was taking it in a slightly different direction, so I don't know if anyone wanted to continue on the vaccination discussion, or I was just picking up on your query really in about postcode lottery, because that's something that very much fascinates me, particularly looking at Devon, and I think others have also all discussed the complexity between urban and rural challenges. What strikes me as interesting, whether central government could or couldn't do anything different, still in my mind as a thought. But integrated care systems we have tried over many decades in many different ways internationally. At the heart of integration is localized delivery for different communities to get the outcomes that they need in an equitable way. That's the aim of integration, is to do things as best as possible for the people that we're looking after. But what happens is we receive a model of integration that needs local interpretation because every locality and every community looks different. And that's I think that's a fair drive, and that's clearly understood. But as soon as you get to that local integration and local definition, what fascinates me is, and I'm doing an MBA at the moment, and my last module was on healthcare policy and this thinking around what makes an integrated care system. And so much is driven by how stakeholders perceive integration and what an integrated system means to each stakeholder. So what fascinated me in this new model, which I think is the closest we've got so far over the decades of how we could make a real difference in integrated care, is stakeholders are no longer just the providers of the care. It is the communities that we serve. It is the different organisations across different landscapes, across different services, all coming to an equal table that isn't an NHS table anymore. It is an equal table of how do we address inequality in health and social care and wider. So my worry is, in all of that, local definition, local interpretation, surely there's no way of avoiding postcode lottery in that respect, because each system is approaching this in such a different way. And what I hate to watch, and what really frustrates me, because it drives inequality across our health and social care system, is the inability to be fleet of foot in how we learn from each other. We reinvent the wheel so often because there is so much going on across our systems that we can't be everywhere all of the time learning from that great practice. But there is brilliant practice going on all over the UK, and we're not necessarily connecting those dots fast enough. And the NHS specifically, I don't think, has the ability to do that on its own. So it's whether or not there is wider help and support in how we learn faster and avoid some of the potentially unavoidable postcode lottery that's going to come from integrated care in how we're approaching it. I mean, that's just my perspective, but that is a worry I've got as much as it is a motivation for me in my health inequalities work.
So let's expand on that with you, because postcode lotteries aren't just a difference between, I don't know, Liverpool and Tunbridge Wells. They can operate within a region as well. I mean, your area, I mean, it is quite a diverse region, isn't it? I mean, presumably you find that there is a different outcome in one part of your area compared to another.
Absolutely. And we've got, again, thinking about what Patricia said, sometimes people think about rural leafy Sussex, but within that we've got Crawley, which is diverse. And so even within a postcode, some population metrics might mask some individual needs. So I was just thinking about, it's both and. You almost need to be looking underneath the postcode so that you can identify the specific individual needs within communities. But actually, when we're talking about an integrated care system, we also need to go beyond health and social care to education and housing. And a lot of our initiatives have been working with schools, with our Kickstart scheme, where we've worked with the unemployed who are on universal credit to give them work experience. It's kind of broader. So it's, for me, the integrated care system needs to be fully integrated. But yes, absolutely, we have got areas of Brighton and Hove along the coast where we've got micro areas of deprivation. And if you looked at population level, you wouldn't necessarily see those.
Helen, I was struck by what somebody said earlier about racial diversity here. One of the things during the pandemic, which I must admit quite shocked me, was the level of distrust there is within some ethnic minority communities of the NHS. And that was the reason why many would not get the vaccine. And a thread that I think has run through what everybody said today is that in order to maybe gain trust, to regain trust, you have to get out there in the community. What's happening in Northeast London so you can try and get people back on side, if that's the right expression?
So I think in Northeast London, and I think maybe Anne might be able to say a little bit more, but we've been doing a lot of work, particularly with kind of community leaders, faith leaders and others, to try and do a lot more outreach. They are trusted voices within the community. And where, as Anne was saying, the NHS sometimes, and it's something we learned particularly during the pandemic, the NHS is, you know, we think of the NHS as being one of the most credible and trusted institutions in the country, and for the kind of large majority of the public it ranks very highly. But when you break that down, there are certain groups of people who don't place high trust in the NHS, and it's those groups that we need to reach. And we really need to target. And the way that we did that during the pandemic was by working with community and faith leaders and other trusted voices in the community. Just before I hand over on that, though, I just wanted to make the point. So before you were talking about, you know, the kind of differences within localities and inequalities across geographies. And I was just going to say, one of the things that I have a slight concern about with ICSs, and I do think integrated care systems, and I do think they are the right direction of travel, is the importance of looking under the bonnet of integrated care systems and the data. So if we start just looking at ICS, integrated care system metrics, and not getting underneath those metrics, we will be masking a whole load of inequalities. You know, when you take North East London as an integrated care system, it's vast, it covers a huge geography. And we really do need to kind of get under that data and look at locality data to understand what's really going on.
There's a lot of nodding going on with everybody, but feel free to shake your head and disagree at any point. Jackie.
That was the point I was going to build on, and it also links to this point about postcode lottery. Sometimes there should be a postcode, not lottery, but there should be a postcode differentiation, because different postcodes have got different needs. And I think that, you know, Helen was identifying the challenge of North East London. You know, I talked about some of the common issues that we have in North East London, but actually, if you take Havering, it's a very older population compared to Newham, which has one of the youngest populations in the country. Even within Tower Hamlets, you've got very, very different health outcomes. I think the healthy age limit is a difference of 15 years in different parts of Tower Hamlet, depending on whether or not you're in a more wealthy area or a less wealthy area. So the only way you can deal with that is what Anne was talking about earlier, which is an important part of the integrated care system development, which is this, what we call in the jargon, place-based system. Basically, that means is at a place, so for Barts Health, we've got 4 hospitals, we cover 3 boroughs. In Barking, Havering and Redbridge, there are another 3 boroughs and another 2 hospitals. In each of those areas, you've got to build a relationship with local community groups, with the local government. And one of the real challenges for us in the NHS is that we always tend to think of ourselves as a national organisation. So although we work in individual organisations, we sort of have this idea that it covers the whole of England in a similar way, when it absolutely doesn't. And there's national policy, whereas what it would, I think, be helpful to do in tackling some of the inequalities that we've been talking about is to give a bit more power and a bit more influence to local government, so that when you're working in these local areas, the things that are also going to affect health, housing, schools, whether or not air quality, all sorts of things that actually local government has a really big say over, could also be brought into the work that we're doing. And that's when we talk about place-based working, that's what we mean, building those partnerships and dealing with those issues at a local level. So we've got a project at Barts Health that works across well over 35 schools. We've got relationships with local colleges where we can actually look at local people, the challenges that they have, how we can employ them in the NHS, because let's not forget, as well as treating people, we also employ a load of people in the local area, and we can help to counter health inequalities by giving people real access to really good jobs in the NHS as well, and that's something that we've been working at in Barts Health.
Okay, Patricia, you wanted to come in.
yes, really struck by the conversation, and particularly Laura's points and Helen around, should there ever be a postcode lottery, and with ICSs, are you going to perpetuate that? And I think Jackie sort of answered that question beautifully in terms of it's not a postcode lottery that we should be perpetuating, but we should accept differences in local communities, and therefore how we deliver health and social care services will be different based on the needs of the population. And therein lies some of the solution. I think we have to move towards, we talk about population health, but actually taking a population health focus, understanding that data, having the one version of the truth, knowing where our populations are, and not just knowing where our populations are, getting out there and actively listening and having that discussion with them, so that you can sort of build greater sustainable communities and really start to design services that meet the needs of the individuals in an integrated way. So I don't think it's about how we perpetuate postcode lotteries. I think it's how we utilise population health. I absolutely agree. The three greatest determinants of health and have the biggest impact on my services are house, job, friend. Those three things are the most important in terms of improving the health of the population and reducing inequalities. And that goes back to Helen's point, absolutely. So ICSs need to get into the space of population health and to start to measure metrics in a very different way, which will mean that us as an NHS institution needs to change that focus, because the whole performance management framework in health is waiting lists, A&E targets, which are all very important quality measures. But actually, whether you're delivering the 4-hour standard in Redbridge or Shropshire or wherever, will have diddly squat impact on reducing your health inequalities for the community. So it requires the performance management machine of health to think very, very differently, and how we invest as a health system very, very differently in the future, I think.
Well, one of the advantages of working for a big institution, a nationwide institution, is that I guess people can learn from each other all over the country. Is there some sort of, I don't know, best practice portal where if you have an initiative in your local area and it works really well, you can sort of upload the details so other people can sort of see what you've done and maybe learn from it? Anne, can you answer that?
Yes, is the answer. So yeah, there is a national platform called Futures NHS, and certainly that's been used widely over the last couple of years just to kind of share that kind of learning. I think one of the things that is great about that is that, we're dealing with people, we're dealing with some very similar challenges. So therefore learning from each other is incredibly helpful. The other thing to remember comes back to the differences between populations. And I know sometimes in London, we found it a little frustrating to be performance managed on our work on inequalities and being compared to other parts of the country where the population is completely different. And so yeah, there's learning in terms of how we do things, but how we apply these to our populations comes back to that difference, and that difference very much at a hyperlocal level. And if we focus at a hyperlocal level, that's where we can absolutely make the difference. And I know you're encouraging us to disagree, but it's not going to happen.
I'm going to disagree. I'm going to disagree.
Fight. Go on then.
I'm going to agree and disagree. No, there is a role for the national NHS and in fact for national government. So, I made the case that action needs to happen at a local level and in local partnerships. But there are also things that should happen at a national level. And that is some of the policy changes that, and I'm not making a party political point, but sometimes this government has backed off. So what's been one of the most successful things that has tackled health inequalities in the last 20 years in this country? It's a smoking ban. And it took a government to put that in place. And the focus that we've now got on individual responsibility, I think, is preventing us from doing some of the things, taxing high fat and high sugar foods, other national policies that could even cut smoking further, for example, that would have a massive impact on health outcomes and that would, as the smoking ban has, support people with in the most deprived groups and the most needy groups more than others. So there's national action that's needed as well. And I don't think that, I think because of a fear of nanny state, because of a over dependence on individual responsibility, I don't think that that's happening enough at the moment.
How do you ensure that the services you provide don't exacerbate inequalities? Because I'm sure that's happened on occasion. Has any of you got any experience in that area? None of you.
Yeah,
Anne.
Yeah, and that's exactly what we were doing with the vaccine programme last year. And it's about rigorous measurement of uptake, but also starting to get insights from the populations themselves. And that comes back to, I think, what Patricia was talking about a little bit earlier. We need to be doing this differently. So it's not just about data, and it builds on Helen's point as well. It's data to insights to action. So we would consistently and persistently measure uptake from different populations, using the white British uptake as a marker in the sand, not as a target, but as a marker in the sand, recognising that it will be the white British population who will be the ones who would run towards, in general, run towards a COVID vaccination, and other communities would be more hesitant. And that's what we found.
Was that right from the start, or was it a bit of a revelation to you that actually there were communities where the uptake was so low?
It was a revelation to me, but again, that comes back to me not focusing on inequalities in my healthcare career up to this point. I think it was from those who've been working in vaccine and immunisations for years, it would be no surprise. Yeah, so but perhaps their voice hasn't been heard enough in the conversations that we've had around inequalities. So it was rigorous measurement, it was then getting insights from communities, and then it was taking action in response to that in a kind of an improvement cycle type of way, and then coming back and measuring again. But the insights from the communities are the things that actually make the difference in terms of the actions that we took.
Laura.
I think your question was whether or not were we doing things that were exacerbating inequalities, and I think my answer is slightly aside, in that we look after people who have mental illness or mental ill health with a learning disability or neurodiversity, and what we see is the challenges we face around these disadvantaged communities already experiencing a shorter life expectancy, more complex physical and mental health illness throughout their lives. So they're already in disadvantaged communities, they're already disadvantaged population. Then layering on top of that, the health inequalities and the wider social determinants of health that we're all talking about, all that complexity, faced with sometimes less targeted focus, less targeted funding, and the challenges of balancing what our services are required to provide, what our services are mandated to provide in terms of targets nationally or locally, and where our concerns remain that already disadvantaged populations continue to slip away in terms of national or local focus. And organisations individually or in local areas or otherwise grapple with that on a daily basis. And I think that's you asked at the beginning, what drives us, and I think that's one of the key motivations for all of us in our roles, is that we see those inequalities forming within the populations we're looking after, and sometimes they are very, very difficult challenges to overcome. I suppose it's the lack of rather than the something that we're doing to cause it, but we're seeing the continued impact of some of these groups falling further and further back in priority. And I think that's what our focus now has to change.
We talked a little bit about the challenges of rural areas earlier. Let's develop that a little bit now and expand on it. Sarah, you explained earlier that Sussex is not just a rural area, but I mean, the landmass predominantly is. What's the split in population between urban and rural in the whole of Sussex?
So it's a complete mixture. So we've got, so Brighton and Hove is our centre, sort of geographically, but you've also got Crawley, and then you've got Chichester's quite a big conurbation, but then beyond that you've got very rural, limited, not great road infrastructure and limited public transport. So it's a complete mix, and within some of those rural areas you'll have a mix again. So I think what's interesting is that shows across our staff as well. And I was thinking back to your question about what did we do to support people to take the vaccine. And one of the things we did with our staff networks during COVID was we had regular hangouts. So our Black, Asian, minority ethnic group had hangouts on Zoom. So we sort of made the most of the technology, and we used them not to solve the problem, but to gain insights into what that might be about. So I think where the rural and the non-rural mix happens is it does sometimes exacerbate inequalities because people can't access. We had 5 vaccination centres covering the whole of Sussex, but it was probably harder for some groups to get to those, even though we had 5, and even though we created ways of people getting to them, it wasn't equitable.
That's really surprised me that you only had 5 throughout the whole of Sussex. I mean, I suppose my experience is in London, where they seem to be around every street corner.
So we had 5 core vaccination centres. We also had people delivering the vaccine at home, and that was 5 led by our organisation. They were also in GP surgeries, but 5 sort of big vaccination centres.
Patricia, do you think the pandemic actually helped you maybe learn more about the sort of inequalities between the different areas in your patch?
Completely, and sort of mentioning that sort of a theme here of the vaccination programme, certainly the health inequalities work we did with both local authorities, the heat map of where our populations are and really understanding that in a different way, really highlighted some of where people are and what some of the key issues are. The downside of the pandemic, of course, is that those inequalities have got deeper and wider rather than so our understanding has grown. But the pandemic has created even bigger issues, obviously relating to the sort of local health economy, the job market, and so on. So that's been a real issue for us, being able to create access, the challenge of workforce, the challenge of getting workforce around and bringing communities together has been difficult. That said, we have over 60% of our community is rural. There are real opportunities in some of our rural communities because smaller communities know each other. There tends to be better networks of voluntary sector organisations willing to come forward and work together in a different way. And I think what has been a real eye-opener through the COVID experience for us within health and the local authority is how we can maximise those communities, how we can make them stronger and more sustainable. So, rather than expensive, we talk about house, job, friend, how can we work with communities to try and create a more sustainable environment through bringing businesses, communities, us offering jobs, but other communities offering jobs. Agriculture is a big issue within Shropshire. How do we help support the agricultural community and the economy and so on? So there are advantages of working within rural communities as well that we need to capitalise on. And I think COVID has given us that opportunity to start bringing people together in a different way, I think.
Laura, Devon is a very diverse county. You've got coastal communities, you've got quite remote communities, you've got big city. What are the main challenges of meeting the needs of all of those different diverse communities?
Exactly that. The spread is so distinct. So I'm checking the numbers. The others are doing so well at recalling these to hand. But I think we have, out of our areas, there are 3 wards in the most deprived 10% of all areas in England, really relatively small community populations there. But then there are also 27 areas in Devon that are in the least deprived 10% of areas nationally. Such a spectrum. And I think what Patricia is saying is absolutely right about getting into the hearts of those communities, whether they're coastal, rural, whether they're agricultural communities, whether they're city. It's just, there's such a mix of community aim, community value, and it does go very much to what others have been saying about the localized response needing to be absolutely around those populations, but not what I was saying, I suppose, is we need to learn from where things have been successful rather than a blanket approach, which I think we're all agreeing on. Certainly for Devon, some of the biggest challenges I think are the broad spectrum of where things impact communities. And so for us, in obviously mental health and learning disabilities, mental health has impacted different areas within Devon at very different times throughout, certainly from the pandemic, but beyond, because of the nature and the motivation of that community. So agriculturally, we've seen mental health conditions hit agricultural communities at very, very different times. Our outreach work is very reliant on our partnership with our wider CCG system primary care colleagues. And what we're trying to do now as part of our ICS work is through the community mental health framework and wider, working through place-based PCNs and other organised setups to get into the hearts of those communities and work around the emerging needs. So that, for example, in Torbay, there is some of the most deprived communities in our county, but also sharing a whole range of different community needs. And I think it was, oh gosh, she's gone off the screen. One of our other speakers was speaking, Anne, sorry, I think it was Anne, mentioned about connecting with faith groups and community groups. And that's something that we're seeing is absolutely critical for us now in getting into the hearts of some of these communities.
It's so interesting what you just said about Torbay, because I think most of the rest of us would have thought of Torbay as rather a sort of well-to-do area, but often the reality is masked, isn't it?
Absolutely. And I think what was fascinating when we talk about postcode, this can be one side of a street to another within a town or a city. This is not about, Torbay is affluent and North Devon, Barnstable is not. There is such divide even within these specific areas. And where we were getting sort of caught up, I think, was waiting for population health data to drive our action, whereas some of the conversations that started to happen were, look, we know what the problems are, we know what action we need to take. These GP practices, community nurses, they know the families, they know the streets, they know the housing areas where people are absolutely in need. And if we go for it and we take some really purposeful action, if it's one postcode wrong, at least we've impacted a community positively and know what we're going to do in the next postcode along. So there's a lot to be said for taking positive action, learning when you know.
I'm going to ask Jackie to wrap up in a minute to make some concluding remarks. But before I do that, when you look at the scale of the backlog from the pandemic, whether it's GP appointments, whether it's massive operations, does that threaten to throw this whole agenda off course? Helen?
Yes, I think it does. The scale of the backlog is huge. And I think, one of the things I was going to say earlier is you asked Ian about kind of whether services exacerbated inequalities sometimes. And I think the way in which we do often, the NHS puts in place barriers unwittingly to access. So things like GP practices, they're not meant to require your address to register, but they still do in many cases. I had it the other day happen to me. Also letters being sent by outpatients to addresses that don't exist, that never reach you. We sometimes propose charging £10 for a GP appointment. Hopefully that won't happen. We sometimes propose that we'll start fining patients to attend A&E. These are debates we have nationally. Those barriers those barriers put people off, and they also prevent people who need the care most from accessing it. I think the backlog is another barrier to access, and it's something that we really do need to focus very carefully on. I know that at a national level and at trust level, we are analysing our backlog data to understand who is being impacted most, and trying to make sure that we do minimise those inequalities being exacerbated. There's an initiative called 20+5 at a national level that's trying to focus on making sure we don't do that. But it's a real risk, and it's always a risk, particularly around access.
Anyone else want to come in on that? Patricia?
Yeah, I completely agree. I think there is a huge focus on clearing the backlog, and I get that. We need to get sort of early diagnosis cancer back on the agenda and so on and so forth. But there's something here that about how we don't forget the left shift and the funding and the move into prevention and primary care, all the things that we've described. And I think the blatant focus just on waiting lists and getting those down, yes, for sure, we need to do something about that. But there's a danger then that we don't focus on the identifying people that are at risk and providing early intervention and services. Because if we don't do that, frankly, Helen and Jackie are going to continue to see people coming through the door of A&E with exacerbation of, in the final stages of, stage 4 cancer, because it hasn't been picked up further down the line, in mental health crisis that could have been intervened earlier. So the prevention agenda is at huge risk of being derailed, because we've got a focus of X billion pound has been spent within the NHS, and therefore we've got to get waiting lists down, because that is the key. Going back to Helen's point about the metric, those are the metrics which count and that are being measured nationally. And whilst having national metrics is really important, we need to be measuring the right thing and the right outcome.
Anne, briefly, if you can, please.
Yeah, so the challenge for us is to maintain that focus on inequalities as we are trying to clear that backlog, and particularly that relationship with our local communities, because we have raised expectations in a positive way that we will change the way that we will engage with communities. If we go back on that, it will be even worse than not raising those expectations in the first instance. So we have to maintain this focus.
Well, Jackie Smith, let's come to you for some concluding remarks. What do you think we've all taken out of this last hour?
Well, first of all, it's been a great discussion. So good, in fact, that my laptop overheated, and that's why I for a few minutes. I sort of let the bad news, first of all. The bad news, I'm afraid, is that if recent trends continue, then England as a whole is set to see health inequalities worsen. Some of those that we've been talking about, so that by 2030, up to 48% of men and 43% of women would be obese. That would mean more strokes, more cancer, more diabetes, more coronary heart disease. We've also, of course, seeing the impact of the cost of living crisis. People whose bills are going up, I think that has a disproportionate impact on low-income families, and I suspect we might begin to see the impact of that in children with chest problems, with older people suffering as well. But it's also the good news, and I think a lot of what we focus rightly on today is that these things are avoidable. There are things that we broadly in the health service and more widely can do to impact on them, and that the COVID pandemic has both highlighted how inequalities impact on people, but also through some of the things that we've talked about in relation to the vaccine programme, to the way that we're focusing our recovery, have also shown the way to how we tackle those inequalities as well. But action needs to happen at a variety of levels. At a national level, the NHS, those of us who are working, closer to the front line, need to be given permission in terms of national directives and national targets to focus on this work. Secondly, national policy has got to support it through not just encouraging people to be healthy, but using tax and regulation when necessary to make the changes that will support healthy behaviours. We've got to match that at a local level by reaching out, using all parts of the health service. So we haven't talked much about primary care, about GPs. They've got an enormous impact on what's happening in our communities, and can have, as we all can in a health service, those conversations that help us to address all of the things that are causing people to be unhealthy. Local government and what we're doing at place and with our local partners can make a difference, both in providing us with information, but also getting those local trusted representatives with whom we can work and who can get out health messages as well. And of course, who can make a difference to the other things that are affecting our health, the housing, the employment, the exercise, all of the other things that are going to be determinants of health. And then as providers of health services, and particularly as the largest single employer in the UK, we can use that role, our anchor institution role in terms of employers, to make sure that we're offering good jobs, to ensuring the well-being of our staff, and to getting the message out there about how health more widely can support people. So I feel optimistic about it, because I think there are lots of people in the health service who are now really, and beyond, who are focused on this and working on it. But it's absolutely crucial that we do it, because as Helen said at the beginning, health inequalities are avoidable, they're unfair and systematic, but there are things that we can do about it.
Well, thanks for wrapping up, Jackie. Look, I've learned an awful lot over the last hour to really inform me when I talk about these issues on the radio. And I hope everybody who's watched this last hour, whether they're watching it in the next couple of days or even 2 years' time, will take a lot of the things that I have from this hour. So thank you all very much for taking part in this Purpose Health Coalition webinar. There will be some more of these webinars on slightly different subjects in the next few weeks. Hope you'll join us. Goodbye.